for the workshop which we are going to conduct during 23rd to 25th of August, where we will learn more about the muscle anatomy and role of ultrasound guided dry needling in various pain conditions. Today's session about the ultrasound sonoanatomy of neck muscles will help us identify the role of neck muscles in various pain conditions, and neck being important structure which houses all the muscles, important nerves, major blood vessels. Knowing anatomy will help us in planning any interventions for the neck, and knowledge of sonoanatomy is essential as ultrasound has become indispensable part of any modern day pain practice. Our speaker for today, Dr. Madhavi Joshi. Ma'am has been uh, one of the most experienced person. She has done MD, DNB in anesthesiology, and she is fellowship trained in interventional pain management from Maharashtra University of Health Science as well as from Indian Academy of Pain Medicine. Ma'am will provide us insight onto how different muscles contribute to pain syndrome and how ultrasound guided dry needling can be a useful tool in targeting those pain and painful muscles with high precision and specificity. Ma'am also serves as a visiting consultant to various prestigious institutes like Sion Hospital, Nirali Hospital, Sushrusha Hospital, Nahar Medical Center, IIT Bombay Hospital, Holy Spirit Hospital, and ma'am has keen interest in multimodal approach for chronic pain patients with special focus on fluoroscopy and ultrasound guided interventions. Uh, so I welcome you all and I encourage you all to engage actively. Please put up any questions that you might have in the chat box, and we will take questions at the end of the session. And I would also request everybody to kindly mute yourself so as to avoid any unnecessary disturbances. Thank you for joining, and let's have a productive session. Over to you, Madhavi ma'am.
Thank you, Kathy. So welcome all and good evening. So today's topic is applied anatomy and sonoanatomy of neck muscles. As a pain physician, we'll often come across the patients with neck pain. The incidence in 1 year is 10 to 21%. Prevalence is 2,450 per 1 lakh. Female dominates the male patients. The common age group which faces the neck pain will be 50 to 75 years. Now, this is the Lancet paper published in 2021 regarding the rheumatology, and it is a systematic analysis of the global burden of chronic neck pain. So we should thank ourselves. We fall in the lowest category, that is age standardized prevalence is 910 to 2,200. Now, common causes of neck pain will be muscle pain, muscle spasm, headache, facet joint pains, nerve pain, referred pain, facial pain, TM joint pain, as well as bone pain. So, the muscle pain will be from aching, it will be like aching or sore neck and shoulder muscles in response to overexertion or prolonged physical or emotional stress. We can also feel the tender spots called trigger points in these muscles. Okay. Then comes the muscle spasm. Muscle spasm will appear as sudden. There will be sudden tightening of neck muscles. Patient will be unable to move the neck. It will hurt. And there is often no clear cause, but sometimes it also comes from muscle injury, spinal disc problems, nerve problems, or even from emotional stress. Neck pain related to headache. Okay, it is often most common felt in the back of the head and upper neck and is usually the result of muscle tension or spasm. It is usually dull or aching rather than sharp. The neck might also feel stiff or tender, and moving the neck will make it worse. Regarding the neck pain coming from the facet joint, it will be deep, sharp, or aching. Pain in the facet joint typically worsens when the patient leans the head towards the affected side. And it may also radiate to his or her shoulder or upper back. As other arthritis, this arthritis in the facet joint may also feel the worst in the morning and after a period of inactivity. Now, nerve pain might come from irritation or pinching at the roots of the nerve at the spinal level. The pain will be like radicular pain, sharp, fleeting, severe, accompanied by pins and needles. Depending on the nerve involved, the pain may shoot down the arm or even into the hand. The referred pain might be coming from the heart or any other esophageal condition. Similarly, the pain from the fascia, like the trigeminal area or TM joint pain, patient can have a neck pain. Due to the phenomena of convergence of sensory inputs from trigeminal area and upper cervical nerves at spinal cord level, patient may feel neck pain. These two pains often coexist. Last one is a bony pain. The bones can be tender in the cervical vertebrae, and it is very uncommon. Now, coming to the importance of muscles in the neck pain. As we all know, the chronic pain is the pain which persists even after all other treatment after 3 months. So myofascial pain is present in most of the chronic pain condition. May it arise from bones, joints pathology, neuropathic pain, or any other autoimmune or metabolic conditions. We have to address myofascial component of the pain. So as a pain physician, we do a lot of interventions for the neck and upper back pain, like trigger injections, cervical epidural injections, Botox injections, nerve blocks, pulse radiofrequency ablation of the nerves. But even after we do this, it should be followed by addressing the myofascial pain or trigger points. So ultrasound guided dry needling is the easiest way out. It is the cheapest and it is the safest. So you all will be learning this in the workshop, which will be conducted in the August 23, 24, 25th at Nair Hospital. To know the intervention, sorry, to do the intervention, one has to know the sonoanatomy. To know the sonoanatomy, we have to have a gross anatomy very clear and profound. Now, coming to the gross anatomy, I'm not going into anterior part of the neck because as an anesthetist, we are all aware and we are doing interscalene blocks, we are doing central canalization, so anterior scalene, sternocleidomastoid. So the posterior part of the neck is generally we are not very well versed with, and it is really complicated. Even at this stage, I also feel it's more complicated to remember. So muscles of neck and back, these are divided into extrinsic and intrinsic. Intrinsic muscles will act on the vertebral column. Extrinsic muscle will act, or they functionally belongs to upper limbs and thorax. Coming to the extrinsic muscles is divided into superficial and intermediate. Intrinsic will be divided into superficial, deep, and deepest. So superficial and extrinsic will be trapezius, levator scapulae, rhomboids major minor. Intermediate will be your serratus posterior superior. The intrinsic muscle will be splenius, capitis cervicis, and erector spinae in superficial group. Semispinalis group will be in deep, multifidus and rotator also in the deep muscles. Deepest layer will be the intertransversae and interspinals. See, this classification vary from paper to paper. Some classification add erector spinae as an intermediate group. Doesn't matter. So coming to the transverse section at C6, I just want to show you the facial layer. So this is the investing fascia, superficial layer and deeper layer, which will cover the trapezius from posterior and sternocleidomastoid from anterior. The nerve supply to sternocleido and trapezius is same. That is the spinal accessory nerve. The prevertebral fascia will cover all these muscles These are the scalene muscles, longus colli muscles, erectus spinae muscles, splenius and semispinalis, and levator scapulae. This is the carotid sheath, which will cover internal jugular vein, carotid artery, and the vagus nerve. And this is the pretracheal fascia. So why this is important? Whenever we are doing stellate ganglion block, we have to pierce through the prevertebral fascia underneath the carotid artery and deposit the drug over here. Now coming to the superficial neck and upper back muscles, trapezius, rhomboids minor, rhomboids major, levator scapulae, serratus posterior superior. So this is your trapezius, diamond shaped. It extends from occipital protuberance to spinous process of T12 vertebra. It's a very huge muscle. It also covers, or it is inserted over the lateral part of the clavicle, medial part of the acromion, the spinous process, and the medial border of the scapula. Rhomboids minor. Rhomboids minor is upper thoracic muscle. It is originates from C7 and T1, and it is inserted on the medial border of the scapula. Rhomboids major, again, it is originated from T2 to T5 spinous process, and it is inserted over the medial border of the scapula. Levator scapulae is very, very important muscle because it is the muscle which is in action when we start or when we sit and stand erect. It works against the gravity. So this is the muscle which starts from transverse process of C1 to C4 transverse processes, and which is inserted over the superior medial part of the scapula. Coming to the serratus posterior superior, it is the muscle originating from C7 to T3, and it is inserting over the ribs T2 to T5. It is the muscle basically used for inspiration. So deep neck muscles, as I have explained, these are the splenius group, intermediate erectus spinae group, semispinalis group, multifidus, rotators, and important are suboccipital muscles. The deepest will be the intertransversera and interspinals. It's difficult to understand when I have written, but now we have a figure I can explain. So here we are not present just to memorize origin and insertion. I want all of you to understand the path of the muscle. Like suppose this is splenius capitis and splenius cervicis, superficial layer. Okay, it is starting from C7, C4, C5, C6, T3. Spinous processes, and see the fibers of the muscle which are fanning out from medial to lateral, and it is getting inserted over the mastoid bone. The splenius cervicis also starts from the spinous process and supraspinous ligament of T4 to T6. It also fans out from medial to lateral, and it's getting inserted over the transverse process of upper cervical vertebrae. Why this is all important? For sonoanatomy. Suppose I keep my probe over here. What all structures should I see? It is the superficial layer will be the trapezius. Underneath that will be your semispinalis capitis. And below that will be your suboccipital muscles. But if I move my probe little laterally, I should be able to see the splenius capitis as the muscle which is beneath the trapezius. If I put my probe down at C4, C5, just see here my semispinalis was the second layer. If I come down over here, the splenius capitis become the second layer just beneath the trapezius, and below that will be my semispinalis capitis. So just remember the muscle fibers, how they are going. If in case of difficulty, follow the bony landmarks, get your probe, move your probe up and down, and then understand the anatomy. Coming to the contents of the suboccipital triangle, which is very, very important as a pain physician. The greater occipital nerve block will be done at this level. So suboccipital triangle is basically consisting of suboccipital muscles. Now look at the anatomy. This is the C2 spinous process bifid. This is posterior tubercle of C1. At C2, there are two suboccipital muscles originating. This is the posterior rectus capitis major, and this is inferior oblique capitis. Inferior oblique is going slanting position and it is getting inserted over T1 transverse process. The posterior rectus capitis will be getting inserted over the inferior nuchal ligament or area. The posterior rectus minor will originate from C1 and it will again originate, get inserted at occipital bone. This is your superior oblique capitis, again getting inserted over the occipital area. This form the triangle, and through this triangle, your greater occipital nerve arises. Also the suboccipital nerve. The suboccipital nerve supplies the suboccipital muscles. It also supplies to semispinalis capitis. Some branch also comes from greater occipital and which supplies to semispinalis capitis. This is the lateral view of the neck. As you all are aware, I should not tell you, this is the sternocleido, trapezius. This is your splenius capitis. These are your scalens, and this is your levator scapulae. This area you will be using for your superficial cervical plexus, for your spinal accessory nerve block, dorsoscapular nerve block, brachial plexus nerve block. Coming to the anterior part of the neck, briefly go through. This is your sternocleidomastoid. These are your scalens. This is your trapezius, and this is your inferior belly of the omohyoid. This is the hyoid bone. This is the thyroid cartilage. This is the cricoid cartilage. It is at C6 level. The chest and neck tubercles will be over here. So your stellate ganglion block, you should be at this level. This is the deeper flexus of the neck, longest capitis and longest colli. So this is very confusing, but trapezius I have taken specifically because it has three fibers, superior, transverse, and inferior. All three fibers have different actions. All three fibers have different insertion and different movements. Okay, so trapezius as a superior fiber, it arises from nuchal line, external occipital protuberance, nuchal ligament C1 to C6. Transverse fibers originates from spinous process and supraspinous ligament of T1 to T4, sometimes C7 to T3. Inferior fibers, spinous processes and spinous ligament of T4 to T12. Now, where does the superior fiber going? They are going towards the lateral third of clavicle. Here, it is going to medial acromion and the superior crest of scapula. And inferior fibers are going at the tubercle at lateral apex of medial border of scapula. So what are their actions? Unilateral contraction of superior fiber will cause lateral flexion and contralateral rotation of head. The bilateral contraction will cause extension of the neck. Along with levator scapulae, it will be the elevation of the scapula. Transverse fibers, along with rhomboids, it will cause retraction of scapula. Along with serratus anterior, there will be internal rotation of the scapula. Inferior fibers again causes depression of the scapula, and along with superior fibers, it causes rotation of scapula. The nerve supply is same. The accessory nerve and anterior rami of C3, C4. Trapezius will be one of the important muscle for you in chronic neck pain patients. Chronic trapezitis is a well-known entity. So for my convenience, I have selected different propositions. It will be above C2, at C2, at C4-5, at superomedial border of scapula, and at mid-scapular level. Now I will tell you the importance. So look at the diagram. This is the C1 and this is the C2 vertebra. What is happening above C2? Above C2, all your suboccipital muscles exist. At C2, your semispinalis is just beneath the trapezius, above C2. And your splenius capitis is lateral. At C2, you will be seeing the inferior oblique capitis. You will be seeing rhomboidis, posterior rectus capitis major, as well as greater occipital now. At C4, 5 or 6 level, you will be seeing the splenius capitis muscle just beneath the trapezius. As I mentioned before, it is lateral over here, but it becomes the next layer under the trapezius, and below that will be your semispinalis capitis. At superior-medial border of scapula and at mid-scapular level. So this is the table I have made regarding the various vertebrae at C1, C2, C3, C4, C5, C6, C7. I am not going in detail because it will be thoroughly confusing. But once you are very well versed with all the neck muscles, you come to this table and you will understand the importance. Nowhere this table is given. I have made for this because I want to be clear in my head at what level which muscles I should see. For example, at C2, the origin will be from spinous process is superior fiber of trapezius, rectus capitis posterior major, and inferior obliquus capitis. Now, where is this getting inserted? So, inferior obliquus capitis is getting inserted over the transverse process of C1. Where is rectus capitis posterior major getting inserted? It is getting inserted at inferior nuchal line. Now look at the mastoid bone. There are 3 strong muscles which get inserted over the mastoid bone. The most powerful flexor of the neck, sternocleidomastoid. The most powerful extensor of the neck will be your splenius capitis and longissimus capitis. So these are antagonist muscle and it will keep the neck into balanced position. So this you will understand looking at this table. Okay, now coming to the next, just giving examples. I'm not going into details. Like articular surface at C4, C5, C6, you will be seeing semispinalis capitis. So whenever you will keep the probe at longitudinal section over the facet joint of C4, C5, C6, you should be able to see the semispinalis capitis muscle covering the facet joint. Now coming to the T1 vertebra, suppose I am at the spinous process. See the bunch of muscles which are getting originated and the muscles which are getting inserted at T1. It is a transverse fiber of trapezius, rhomboids minor, serratus posterior superior, splenius capitis, spinalis capitis, and cervicis. The muscle getting inserted will be your semispinalis thoracis, rotatus, brevis, and longa. Don't get confused. Don't get overwhelmed. The point is that looking at the table, one should know what is happening at this level. This is the complete table. Now, big relief. Muscles and neck movements. So which are the muscles which are causing flexion? This is the sternocleidomastoid, longus colli, longus capitis, scalene, and rectus capitis will cause flexion of the neck. Trapezius, splenius capitis, semispinalis capitis, splenius, semispinalis, longissimus cervicis, and capitis will cause extension. So now opposite action, these are antagonists of each other. These are synergists for each other. These are synergists for each other. Strong flexor, sternocleidomastoid, strong extensor, splenius capitis, very strong muscles. The lateral flexion will be the unilateral contraction of sternocleidomastoid, scalenes, splenius, semispinalis, and longissimus. Same with rotation. Sternocleidomastoid opposite side, when it contracts, will form the rotation of the opposite side. Same side splenius, semispinalis, and longissimus. Another classification for neck extensor is cervical neck extensor and craniocervical extensor. Just briefly go through, they are divided into layer 4. First is trapezius levator, 2 is splenius capitis cervicis, 3 is semispinalis capitis, 4th is semispinalis cervicis. Multifidus, but basically the multifidus is acting as a segmental stabilizer rather than extensor. Coming to the craniocervical, that is the junction between the cranium and the cervical vertebrae. It is mainly they provide the proprioception, input to visual and vestibular system. So these are all suboccipital muscles. Any dysfunction will result in sensory motor impairment, altered kinesthetic sense such as reduced balance, joint position, sense error, altered oculomotor control, and can lead to cervicogenic dizziness. So any dysfunction in this suboccipital muscle can cause all these problems along with the neck pain. If you treat these muscles, all this problem will vanish. Now coming to this, I am also bored. You are also bored. So we will take a quiz. I will give you some clues you have to answer. This is a muscle, very strong extensor, starting from spinous process at supraspinous ligament of T1 to T3, panning out medial to lateral, getting inserted over mastoid bone. Can anybody answer?
Semispinalis capitis.
No. This is going laterally. It is inserted over the mastoid bone. So there are only 3 muscles which get inserted over the mastoid. One is sternocleido. Second is
We have few answers in the chat box. Obliquus
Kathy, can you tell me, because I don't want
obliquus capitis.
Somebody answered correctly. Some lady answered correctly.
Okay.
I don't know.
This is splenius capitis. Okay. This is the second muscle. I will give you the clues. This will originate from the spinous process of T4 to T6. Again, this is also fanning out from medial to lateral, getting inserted over the transverse process of upper cervical vertebrae. This is also an extensor of the neck. And this comes into same group.
Splenius cervicis.
Very good. This is not a big task, but can somebody answer these muscles?
Rectus capitis posterior major minor and oblique capitis inferior superior.
Very good. So these are the suboccipital muscles. Now, this is the muscle. I will give the clue. It will originate from transverse processes of T1 to T6. Such a long muscle. Just imagine. From transverse process of T1 to T6, it also originates from articular surface of C4 to C7. It goes little medially and gets inserted over the occipital bone. It is, which is this muscle?
Longissimus cervicis.
Any other guess? It is inserting over the occipital bone. So it is definitely.
Longissimus capitis.
Any other guess? The muscle which is just beneath the trapezius at C1 level. Just.
Semispinalis.
Yes, it is a semispinalis capitis. This is semispinalis cervicis. Okay. Now these are the deepest layer of muscles which originate from articular surface and gets inserted to the 1 level, 2 level, or 3 level above the spinous processes. Which are these muscles? Deepest layer.
Multifidus.
Very good. Very good. The next slide. Somebody has already answered, but I'm again giving the clue. This is also extensor. It is inserting over the mastoid bone. It starts from transverse process of T1, T2, T3.
Levator scapulae.
Sorry?
Levator scapulae.
No, levator is not capitis. Somebody answered before first slide or second slide. It is a longissimus capitis. Okay. Now these are erector spinae group. These are spinalis muscle, spinalis cervicis, and spinalis thoracis. This is longissimus cervicis. Which is this muscle? Somehow it starts from superior medial, or it is inserted over the superior medial border of scapula, and it starts from C1 to C4 transverse processes.
This is the levator scapulae.
Correct. I'm not going to ask this question. This muscle and this muscle. Which are these muscles? These are the
Longest-
deepest.
Longest one.
Yes. This is
Longest capitis.
correct. Very good. Now can we move to the next slide? So this slide I really like, because at which level, how are the muscle placed from C2 to C7? I want all of you just to concentrate on trapezius, okay? At C2 level, trapezius is very tiny. It is the superficial muscle. Concentrate on sternocleidomastoid also at the same time. These two are the superficial muscles. Here at C2, sternocleido is literally posterior muscle. As you go down, you will see the bulk of the sternocleido is increasing and it is going little anteriorly. Trapezius is also bigger. At C5, huge trapezius. At C7, really big trapezius. And sternocleido is going anteriorly and covering the carotids. At C5 also, sternocleidomastoid is anterolateral. Now look at the semispinalis capitis. It is just beneath the trapezius at higher level. And your splenius capitis is lateral. Now observe as you go down, it's coming more medially beneath the trapezius, and semispinalis is pushed down. Can you see? All of you appreciate all this? Look at the levator scapulae. How is it happening? Levator scapulae is a big chunk at C3, C5, C7. It is really passing underneath the trapezius all the way down till the scapula. So whenever you have difficulty, just move your probe up and down, get your queries sorted with the help of bones, joints, whichever, then vascular structures. And you will be able to do a good sonoanatomy examination. Now at C12 level, this is the picture. This is the C1 posterior tubercle. You will see the trapezius, semispinalis capitis, and this will be your suboccipital muscles. At the C2, see, again I'm telling, it depends on the patient. If the patient is thin, you will be using linear probe. If the patient is bulky, one will be using curvy linear probe. Then how you keep your probe, cephalad tilting and caudate tilting can make a lot of difference at this level. So coming to C2 spinous process, this is the lamina. You will see inferior oblique capitis here, trapezius and semispinalis, but I can see a muscle over here. And probably this is the muscle posterior rectus capitis major, which is starting from C2. This is another picture taken. This is the probe, which is medial side is on C2 spinous process. lateral is on C1 transverse process. This is the longitudinal section. This is your C2 inferior oblique, all the way going to C1 transverse. This is a semispinalis capitis, and your greater occipital nerve will lie in between semispinalis and inferior oblique. So while doing the intervention, one has to be very clear where does the nerve lie. Your needle will come from here, you will hydrodissect at this level and then deposit your drug. Now the probe is kept longitudinal. This is C1 lamina, this is C2 lamina. Your transverse section of inferior oblique capitis will be like this. Rectus capitis posterior major will be like this. And these will be two muscles, splenius capitis and semispinalis capitis at this level. Again, the same, I will be repeating because these are important structures. With different machines and different patients, different subjects, you will see different kind of picture. Now, this is not a clear picture, but once you understand the anatomy, you can imagine the greater occipital nerve will be lying over here. Now, the probe has been kept at below C2 level, that is C3, C4 or whatever. The muscular structure, now see the splenius capitis coming medially, overlapping the semispinalis capitis. Below will be your semispinalis cervicis, and below that will be your deep cervical muscles. Now I have kept my probe over the lateral aspect of C4. This is your posterior tubercle. This is your articular process. Probably this is the lamina. Splenius capitis will be over here. Articular processes of C4, C5, C6 will be covered with semispinalis capitis. This will be important while giving facet joint or median nerve blocks under ultrasonography. This muscle will be your semispinalis capitis. This is levator scapulae. Probably this is your medial scalene. Again, at the transverse process of probably C4, C5, whatever, this will be your longissimus capitis, splenius cervicis, splenius capitis, and semispinalis capitis. Same at C5 level. Now coming to down over the scapular level, I have kept my probe in the longitudinal section over the suprascapular area. What I see will be the ribs first, ribs, then the pleura. These are the intercostal muscles. This thin layer of muscle might be of serrato-posterior superior. The huge chunk of muscle will be your trapezius. Trapezius is really thick in this part. Underneath will be your levator scapulae muscle. This structure is important to give trigger injection, facial plane blocks, etc. Just see that pleura is extremely superficial in this area. One has to be very careful while doing the ultrasono-guided intervention. Keep the tip of the needle under vision so as to avoid any mishap. Now, this is a different probe position. I am just over the medial border, superior medial border of the scapula. The picture is like this. This will be my trapezius. This will be my rhomboid minor. Small triangle, which I am able to see, might be the insertion of levator scapulae. This is your serratus posterior superior. These are intercostal muscle, and this is the pleura. Again, the pleura is very, very superficial at in this area. Now my probe is parallel to the medial border of the scapula, probably over T5, T4, 5, 6. These are the ribs I can see. This is the pleura. These are the intercostal muscles. And just above that, I can see the rhomboids major. And this is my trapezius. If I move my probe little medially, I should be able to see a layer of muscle here. That will be my erector spinae muscle group. Now coming to the anterior. This is the only picture I have because I'm not going into detail for anterior neck. This is a stellate ganglion block at C6 transverse process, that is the Chesenbach's tubercle. This is the longus colli muscle. This will be your sternocleidomastoid, carotid, internal jugular vein, and thyroid. Your prevertebral fascia will be covering your longus colli muscle. So whenever you are giving stellate ganglion block, your needle will come like this and pierce the prevertebral fascia, and you will be able to deposit the drug. What is here? As you see, lot of vascular structures in the neck. One has to be very, very careful while performing any intervention. Main is the vertebral artery. As you see, from C6, vertebral artery is entering the, this is wrong, C6 here and C7 should be here. So vertebral artery is entering into the transverse foramina. And at C7 transverse process, it is not being covered. So one has to be very careful at this level. Coming to the applied anatomy and physiology, the Travel and Simmons has published a book regarding the about the trigger point called myofascial pain and dysfunction. This is like Bible to us. As you all know, there are trigger points in the muscles and which can cause the referred pain in other body parts. So you have to listen to the history very carefully, examine the patient carefully, and find out the cause. As mentioned here, upper trapezius, middle trapezius, and lower trapezius. Upper trapezius trigger points can cause referred pain over this area. Periorbital, temporal, occipital, over the sternocleidomastoid, as well as at the lower jaw and occipital. The middle fibers can cause the pain over the mid-scapular area. The lower fiber can cause pain over the shoulder, over the arm, over the paraspinal area at the occipital bone. The levator scapulae trigger points can cause the referred pain in this area. It can be over the shoulder also. Coming to the semispinalis capitis, it's a huge muscle starting from occipital bone till the transverse process of T6. The location over here, the upper fibers trigger points can cause the pain like a migraine. It is a band-like. The middle semispinalis can cause pain at the occipital area. The multifida can refer the pain like this. Splenius capitis, one can feel the pain on the top of the head, over the periorbital area. Sternocleidomastoid, another muscle, very important muscle. The trigger points in the sternocleidomastoid, just see the area covered by the referred pain. It is a mastoid area, top of the head, periorbital, facial pain, under the jaw. So clavicular portion, again the frontal pain. So all this pain can be because of the sternocleidomastoid muscle. Splenius cervicis also can cause pain at the nape of the neck. Semispinalis, longissimus, multifidi, rotators. This is a splenius cervicis, upper trigger points, lower trigger points. Now there is something called Hackett referral pattern. This is for prolotherapy people. What they consider is the trigger points exist in the ligaments and tendons too. This is the superior nuchal ligament. The trigger point at A can cause pain over the frontal part. At B can cause pain over the zygomatic area and the nasal area. At C can cause pain over the temporal area. As well as the ligaments at C1, C2, C3 can cause pain over the back of the neck, C4, C5 can cause pain all the way till the fingers, and C6, C7 over the posterior aspect of the arm, forearm, and the fingers. I'm just explaining the concept. Now, there is a concept called convergence of sensory input. There is a strong association of facial pain and the neck pain. The trigeminal nerve, which is a basically cranial nerve, has nucleus, lower nucleus, it exists in the upper cervical cord. And C1, C2, C3 sensory input also gets converged at the same level. And the patient suffering from trigeminal neuralgia or TM joint pain or facial pain can also have neck pain because of this phenomena. Coming to the facet joint pain, this is a picture. It's a very confusing picture, overlapping picture, but one has to examine the patient and ruling out other causes. One can do the test dose for the facet joint or medial branch and confirm the facet joint pain. This is the area covered by C2, C3, C3, C4, 4, 5, 5, 6, 6, 7, and C7, T1. This is a table which I have made. These are regarding the cervical radiculopathy. Myotomes of cervical nerves. What is myotome? It is a group of muscles supplied by particular root of the spinal nerve. Now, what will be the myotome of C5 will be deltoid bicep brachialis. What about C7 will be triceps and extensors of fingers. C8 will be flexor of the wrist and flexors of the fingers. T1 will be intrinsic muscles of the hand. So one has to be very careful while examining the patient. You can also test all these muscles if patient is having cervical radiculopathy. Now coming to the postures, lifestyle issues, and neck pain. As you all can see, this is the erect posture. This patient, this person is bending a little forward, stooping shoulders. So what is happening here? There are deep neck flexors. These are very weak. Their lower traps and serratus anteriors are weak. So in turn, what is happening is his upper trapezius fibers and levator scapulae and the pectoralis muscles getting extremely tight. They have to take the whole brunt, and there are trigger points which are forming over here, and patient can have an anterior chest pain and neck pain. Now this is the common scenario which we all can see, holding the mobile and typing constantly throughout the day and night. What is happening here? This person is bending the head, holding the hand. So the pectoralis major, the deltoid, the trapezius, splenius capitis, semispinalis capitis, and the sternocleidomastoid, they're all getting much strained, stretched, trigger points forming over here, and patient is getting severe neck and upper back pain. Lifestyle, patient is working at the desk throughout the day, a very bad ergonomics. Patient is bending forward, having a very poor nutrition and no exercise. Ultimately, what is going to happen is patient is going to get neck pain, upper back pain. This lady is typing, holding the phone, bending the neck on one side constantly. Again, the muscles are getting strained, and this is the mechanical cause of having neck pain. While driving, again, this patient is bending forward, stooping shoulders. Ultimately, she will suffer. What is actually happening when the person is bending? When in normal posture, the spinal column is taking the pressure or weight of 12 pounds. When the person bends 2 inches forward, the pressure on the spinal column increases by 20 pounds. When the patient bends 3 inches forward, the spinal column is taking pressure more of 30 pounds. All these posterior ligaments are stretched, the muscles are stretched, and patient is having a neck pain because of the posture. Same thing happening over here. With this posture, here is taking spinal cord is taking 5 kg load. Here it's taking 28 kg load. So this is called forward head syndrome. What all can cause because of this? Everything on the earth. Patient can have headache, migraine, dizziness, neck pain, EM joint pain, acid reflux, shoulder pain, back pain, low edges arm, pinch nerve, arm pain, numbness, tingling, carpal tunnel syndrome, tennis elbow, rotator cuff issues, fibromyalgia, degenerative disc, joint, whatever, you name it, and this person will have in the long run. So what we should learn and what we should tell our patient is to have a correct posture, good exercise, good nutrition, and meditation. This will solve most of the problems of the patients having neck pain. Thank you.
That was very insightful and informative lecture, Madhavi ma'am. Thank you. And before we move to question answer session, I would like to invite Dr. Lakshmi Vas. Ma'am is director at Ashirwad Pain Clinic and also pioneer of ultrasound guided dry needling. Over to you, ma'am. Ma'am, you are muted.
Yeah, I know. I unmuted myself just now. So, welcome everybody. I'm sorry that I was not there for the first meeting. I was on a silence retreat program, so I apologize for my absence. But I'm happy to see that there are quite a number of people attending this, in more than the registered candidates for the workshop. As you can see from Madhavi's lecture and also Renuka's lecture, there is the muscle structures are extremely complex. And not only are they complex, each muscle is important. Like Madhavi was showing you a slip of muscle called serratus posterior superior. That, unless you address that, the so-called trapezitis will not respond. And unless you address the levator scapulae, things won't settle, because all these muscles were designed for quadruped animals. Now, suddenly we all stood up. And so as a result, these muscles are doing overtime work all the time. And as a result of which, ergonomically, they are not designed for the erect posture, and they are being subjected to the erect posture. So that is the reason why we decided in this workshop that we'll have pre-workshop lectures, so that you are introduced to all these muscles now, and then you will see it again in anatomy, and then again you will see the sonoanatomy, so that at the end of it, things will be fairly clear to you. And also you will hear again and again about which muscle causes pain where. Madhavi was talking about trigeminal neuralgia radiating its pain to the neck muscles. But she also showed you the referral patterns of sternocleidomastoid, of splenius. All these refer pains to the trigeminal area. Just going and doing ablation of the trigeminal ganglion will not take away these pains. They are still there after you have ablated the trigeminal ganglion. So unless you address this, these pains will never settle. So as a result, with all the neural procedures, we solve half the problem maybe, or maybe 1/3 of the problem, and we consider this as a success. Because on a Likert scale, 30% improvement is considered as good improvement, which is a very compromised attitude, if you ask me. If you are a patient, Would you like 30% pain relief or you would like 100% pain relief? So to take that 30% pain relief, which happens with nerve interventions, whether you are doing an epidural, whether you are doing a radio frequency procedure or a facet procedure, whatever that you may be doing, unless you address these muscles, your patients will never go to 100%. Even if they say in the early days, yes, we are better by 60% or 50% or 80%, that percentage is going to go down if you don't address these muscles. So that is the reason why it is so very important to understand muscle anatomy, muscle sonoanatomy, and then treat your patients. Do your epidural, do your radio frequency procedure, whatever you want to do, and then follow it up with either dry needling or with Botox. So many treatments can be done for these people. And then they have to follow it up with physiotherapy. So if we managed to convince all of you that you have to look at the body as a whole and not as just a nerve causing a pain somewhere, our purpose would be achieved. And I had promised Khyati that I'll not go beyond 5 minutes. I hope I've stuck to 5 minutes. So welcome all of you. And so let the discussion start. Thank you.
So we have one question in chat box from Dr. Umesh Ramtani. He had a patient of greater auricular neuralgia. He's asking what treatment options are there. He has tried many things, but patient keeps coming with recurrence every few months.
Madhavi?
Have you tried the pulse radio frequency?
I think we should ask the person what all he has done, because he has said that he has tried many treatments. Please tell us what the treatments are. Please unmute yourself and tell us what the treatments are. Then Madhavi can guide you further.
Initially, I started with some local treatments, like I tried dry needling, then other physiotherapy and other non-pharmacological therapies also. Later on, I gave diagnostic blocks with greater auricular nerve, even lesser occipital nerve I blocked. So some relief she gets, but now pulsed RF, well said by madam. I'm planning for that also, because every 6 months she's keep on coming back with a recurrence. So I will actually pulsed RF I have not tried yet.
Okay. So how much pain relief did the patient get after the dry needling session?
Almost 60 to 70%.
So why don't you repeat the dry needling session again?
I've already done it twice or thrice. But when she comes back, she's having a severe pain. Whenever she comes back, she comes with an increased intensity of pain always.
Okay. Madam, over to you.
Come on now. See, this is what
Actually, I presented this case also. Actually, the treatment options, again, the same things were repeated, but patient is actually not getting benefits still.
Yeah. See, what you're talking about is greater auricular nerve, which means somewhere around the mastoid. Am I right?
Madam, greater auricular travels on sternocleidomastoid.
No.
Yes, in the midpoint of sternocleidomastoid. Posterior border of sternocleidomastoid, I injected the drug. Actually, yes. ENT people went too far and they performed a surgery also, considering it as a Eagle syndrome. They thought that they misdiagnosed it as a long, elongated styloid foramen. So they went too far and she was operated also, but still she is not relieved of pain.
In fact, that would add another aspect to the whole pain of post-surgical pain. Because when people operate, they are cutting muscles, cutting tissues, cutting nerves, which causes fibrosis and more shortening of the whole area. Now, anyway, coming back to what I was talking, greater auricular will be around the mastoid. That is where your pains are. And as Madhavi had told you, there are so many muscles coming to the mastoid. In your dry needling, whether you addressed all these muscles or not is one thing. And after you've done the dry needling, you also have to follow it up with physiotherapy stretches and tell your physiotherapist, look, focus on these muscles, the ones which are inserting to the mastoid. And if dry needling is not providing you long-term answers, then definitely pulsed radio frequency is a very good option. And you have gotten good results with greater auricular nerve or lesser occipital nerve. Which which gave you the better answer in this patient?
Greater auricular. Greater auricular.
Fair enough. Do the PRF of that. But you should also do, if you're taking out the radio frequency machine, you should also do the spinal accessory nerve. You should also address the splenius capitis muscle, the nerve supply to that. You look at Madhavi's beautiful chart she has made. I feel all of you should print out that chart that she has made.
Madam, I have taken a lot of effort to.
I know. I know. I am planning to take that and stick it somewhere in my OT or something.
Because
like
I wanted that in my head. Otherwise, it's very difficult to follow.
I can promise you it will not stay in your head for long. It's better to have it as a ready reminder all the time. So you see, you have to address all these muscles. I mean, all the nerve supply to all these muscles, and then do needling of these muscles in a systematic way. Then I can tell you that this patient, not only will she go down in pain, she will remain in lower pain. And you should tell her whether whatever you do, you have to do the stretches properly. So for all these muscles, you have to tell the physiotherapist to do a proper stretch and teach the patient how to stretch this. And then she should do it on a daily basis. If she does this regularly, there is no reason why she should not have a problem. And also many times, this might be one of the upper facetal problems. It might be C2-3 facet also. Maybe you should, if she does not respond to PRF, then you should look at a test dose to the facet as well. So
once I performed that cervical epidural also with that patient, but again she received only partial relief, some relief, very minimal relief.
You have to do it this way. You have to address the nerve, you have to address the muscle, and you have to support it with physiotherapy thereafter. And in addition, you should also look and see whether this lady has vitamin D3 deficiency, vitamin B12 deficiency, and correct those things. Because she will be...
That all has been investigated.
No,
because
she
is
has
with
to be
me since 3
investigated
years
for.
actually.
Because if you have these deficiencies, you have muscles which are vulnerable to injury. They will form more and more MTRPs again and again. So you have to correct those vitamin levels as well, do the PRF, do the needling, follow it up with physiotherapy. It has to be a holistic treatment. It cannot be just an interventional kind of a treatment. It has to be intervention with lifestyle changes for all these things. And in spite of all that, this lady may come back to you after 6 months or 8 months or 1 year. But when she comes back, if she has been regularly exercising, she will not have this level of pain. She'll not come with severe pains. She will know when to come to you. Many patients at Ashirvad, once they go down in pain to a very decent level, let's say they come with 7-8 pain, they go down to maybe 0 or 1-2 pain, and they keep maintaining there. Sometimes something overbalances in their routine or whatever, or if they are stressed out for something, their pain will go up, and they will come when they are about 4-5. They'll tell us, look, I think my pain is starting now, so I have come to you. If you do needling at that time, the pain disappears again. So you cannot say that this is a patient where we will achieve a cure. Here is a mechanical situation where there is also aging, degenerative changes, and other things which are happening. So you have to consider all this in treatment. Presently, after what you have done, she is coming back to you with severe pain. But if you follow up this, whole treatment, holistic approach to the whole thing, she may still come back to you after a year, but she'll come with lesser pain and she will respond to 1 or 2 sessions of needling thereafter.
Thank you. Thank you.
Yeah.
There is
Anybody else?
one more question. When will patient see clinical effects after PRF?
Madhavi?
Generally, the patients, we see PRF, what they have mentioned in the books is a very short cycle PRF. In practice, what I do is I give PRF for more than 5 to 6 minutes, which has a very good effect. Whenever the nerve is mixed, motor plus sensory, PRF is very useful. And we see the PRF effects within a week.
So here I would like to add, I do it for about 10 minutes, 8 to 10 minutes. I started with 6 minutes, went to 8 minutes. Now I go to 10 minutes almost.
Madam, we can
With
also
this,
do 3 cycles of maybe 3-4 minutes.
Yeah, either you do that or I do 10 minutes continuously. Whatever it is, you give that much PRF to the patient.
Hmm.
And then usually the patients come and tell you the next day that they are better. And then they keep improving for the coming week almost. And then you start dry needling, they will be in a lot better position. But correct those vitamins, sir, please. That is very, very important. You cannot simply prescribe vitamin D3 and B12. You have to see the level. What is the level? If I find that it is 30, I will still give them an injection of D3 because the D3 range is 30 to 100, which is a very foolish range. It has to be 30 to 40 or 90 to 100. When you say 30 to 100, it's a very huge range, which is very unrealistic. So I usually take 75 as my normal. So I believe that all the candidates here will definitely be deficient by this standard of 75. So you should take injections, take your vitamin D levels to 75. And B12 also, 200 to 800 is again a very unrealistic range. So you should take 500 as the normal, and you should see to it that your patient goes there. So the patients, all of them should be investigated and then corrected, not just corrected in a blanket fashion.
Any more question? Anybody? Okay, I think no questions. Thank everyone, each of you. We had
Thank
almost
you, Kathy. Thank you, madam. Thank you, everybody.
Thank you, Madhavi. It was a great presentation.
Thank you.
And your charts, we will all print and keep in our OTs and in our offices so that we can get them. I have made these sometimes, but I have not really printed and kept it. But in fact, for all the candidates, I would like to say one thing, that you make a chart of these muscles and keep looking at it, put it on your phone and you keep looking at it. Because this is what I used to do when I first went for anatomy dissection back in 2006. That is when I realized the complexity of neck musculature. And literally, when the patient gives you the history, he's giving you the diagnosis of what the problem is, which muscle is giving him the problem. So I what I used to do was I used to keep it on my phone and keep looking at it whenever I had nothing else to do. I'll simply look at the muscle layers. So that's the way to fix it in your head. And of course, the sonoanatomy, she has given you very clearly at C2 level, at C4-5 level, above C2, that you don't see splenius capitis. These are all very useful pearls. So remember all these things and keep looking at it again and again. Otherwise, I can guarantee you it will not stay in your head. This lecture will not stay in your head. You have to look at those charts again and again and again. And then when you do sonoanatomy, you keep looking at it. And then when you do dry needling of neck muscles under ultrasound, the anatomy cannot go away from you. It will 100% stay within your head. Yeah, somebody is saying, can you share your PowerPoint? I think we are putting up the presentations in YouTube, if I'm not mistaken. And so anybody can take out that PowerPoint and do whatever they want with it. Actually, you should, Madhavi should write, made by Dr. Madhavi Joshi, in those charts. I'm sure it must have taken hours of preparation for that.
Yeah, still there may be some errors. I don't know.
No, that's okay. See, that much error is allowable.
There is a question asking about the book which you mentioned in one of the slides, the Travel Simon book.
That is the Bible.
Yeah, it is definitely a very remarkable book. And it's taken a lot of pioneering work by both Travel and Simmons. So I think we should all look at it.
This is a book. This is volume 1. There are other volumes also.
Yeah, there are 2 volumes.
Okay.
Any more questions? I think we can conclude the.
Yes.
So thank you, Madhavi ma'am, Lakshmi ma'am, our
Thank you.
organizing team, Dr. Priya, Janvi and Varsha, and Intas Pharma for the support. And we will see you all for the workshop where we'll further discuss these points which we have been discussing in the lectures. And we'll also do dissections and demonstrations of needling on patients as well as volunteer scanning. Do reach out if you want to join and more about the dry needling. Thank you.
Thank you.
Thank you, everyone.